Good morning.
Good morning.
Good morning.
Let's see. Guess we're all here, so I think we should just get going. Okay. All right. So why don't we start here with Sergey Babia. Good morning, Sergey. Where are the catheters? This is from an EP study we recently performed during placement of catheters. Tell me where they are.
Good morning. So the two catheters that are marked by the arrows, the one with the tip looking up is in the coronary sinus.
Mm-hmm.
And the one that's looking down is likely probably in the right ventricle.
Right. In the apex or the outflow tract?
I think it's in the outflow tract.
No.
I mean, well, it looks towards the apex, but it just feels like it's not very deep.
Crossing the tricuspid annulus, that's true, sort of in that direction, but then it acutely is going down towards the apex, right?
Yep.
So why do we put the catheter in the apex most commonly?
To be able to, to pace the ventricles, one goal.
I'm sorry, it was an unclear question. Why do we put it there instead of the outflow tract? Since you brought up the outflow tract, why would we not want to put it there in general? We do sometimes put it there, but most of the time it's in the apex. Why is that? During an EP study. What is the RV catheter? What's it for during the case? You said it's to pace the ventricle. That's true, but be a little more specific than that.
Well, it's also to kind of sense the electrical activity and how it spreads through the ventricle as well.
That's true. Are there any safety reasons that it's there?
That it's in the apex versus the outflow tract.
Is there any safety aspect of a ventricular catheter at all during an EP study? What are we doing during an ablation?
We are basically destroying tissue.
Right. And what tissue do we not want to destroy, usually?
The ones that belongs to the AV node, for example, or
the His system, right? So having a V catheter is a kind of important thing from a safety perspective, because were we to ever have that happen, God forbid, it's nice to know that there is a way of pacing the ventricle at our disposal at any time, right? It's not likely to happen, but it is certainly a possibility during an ablation, more than most procedures. And so the point I'm just trying to make is that the apex is a more stable location for a catheter to sit than the outflow tract. Outflow tract has a tendency to float up into the PA or down. Also, it's easier to perforate the heart in the outflow tract because the walls of the heart are thinner in that area than they are in the apical region. That's one of the reasons also why traditionally right ventricular pacemaker leads are placed in the apex, because it is a more stable location. It's more heavily trabeculated. It is harder to perforate. It is also, by the way, one of the single worst locations to put a pacemaker lead from the perspective of ventricular function. If you could pick an area that is most associated with the lowest cardiac output, it is the right ventricular apex septal region. But that is in fact the most common place that it's placed, because it is also the area where it is the lowest risk of the lead embolizing or moving. So it is still fair to say that most of the time, most pacemaker leads are placed in that location. And during a temporary placement of a V wire, we would normally traditionally put it there for all of those different reasons. Okay, let's move on. This is a patient with Epstein's anomaly, and this is from telemetry in the ICU. And believe that I see that there is an ICU doctor on the line. Dr. Capon is with us. So Ivana, what do you think about this tracing? You're called to look at this by the nursing staff who made this observation.
Good morning.
Hi, Ivana. Thank you for joining us.
Thank you for having me. So when I look at this tracing, it looks like we are in a regular rhythm. He does look, or she looks bradycardic based on the intervals between the P's and the QRS's.
And actually, if you may not be able to see on your screen, but it says that the heart rate is 50.
Oh, sorry. I'm on my cell phone. I'm in the ICU right now.
But it's you're right. It's a slow heart rate. It's 56.
Yeah. So just looking at the rhythm strips, it does look like there is a P before every QRS. That being said, the QRS looks abnormally low in amplitude. I am a little bit torn in terms of what this means because of my limited EKG skills at this time, but it looks like there may be pre-excitation and he is Epstein's, if I remember from the last slide. Looks like a shortened PR interval based
Well,
on the...
what's going on in this tracing? I agree that on the first strip, the patient is definitely appears as if there's a P wave before every QRS. What's going on in the second strip, though? And the third strip. Is that still true?
So in the second strip, it looks like in the first beat, there may be a P leading into a QRS, but then we just have a ventricular beat, it looks like.
And what do you think is happening on these two beats?
I am not sure.
Okay. So we're going to phone a friend here.
Thank you.
I'm going to ask Dr. Alwalia what she thinks is going on here.
Good morning, Dr. Pass. So in that beat that you pointed out, there's no P wave. And in the third strip also, looks like the third beat, there's no P wave. The fourth beat, don't think the deflection before the QRS is what is being conducted. That is probably just like a junctional escape rhythm with an underlying bundle branch block. Slow escape.
Are you saying it's junctional versus, say, ventricular? I agree with you, but I'm just asking why.
So in the beginning, also where we think the P's are being conducted, the QRS looks like that. So it's probably junctional. With ventricular, I would expect it to be a little bit more wider. It's already wide, but it would look different from what it's looking with sinus beats.
So what are our concerns about the rhythm in someone who, if I just told you a patient is going for, with Epstein's anomaly, is going for a tricuspid valve replacement, and you are sitting in the ICU and waiting for the patient to come back from the OR, what type of rhythm problems are you going to be most concerned about, or in theory, about such a patient?
So you can have issues with the sinus node because they're like cutting the atria, like sinus node dysfunction, or AV node, like heart block as well.
Heart block is one of the most important concerns, right? The surgeon has to suture all along the tricuspid annulus, and that includes the Well, what are the borders of, what is the triangle of Koch?
So septal leaflet of the tricuspid valve, mouth of the coronary sinus, and what did I say? Mouth of the coronary sinus, septal tendon of Rodero,
Right. And what sits in the triangle of Koch?
AV node,
The AV node.
AV node. Yeah.
So the septal leaflet of
The
the
leaflet.
tricuspid valve is by definition on the tricuspid valve. And
Yeah.
so when you're sewing a valve into the tricuspid annulus, almost by definition, you're going to be placing some sutures in the area of a patient's AV node. So
Right.
always,
So I mean,
always we're concerned about that.
right.
In fact, we're so concerned about it that if somebody, you know, and of course, the thing you don't want to have to do is to place a transvenous lead across a brand new tricuspid valve prosthesis. So this is one of the cases where most surgeons, although they would often in an adult-sized patient send them to people like me to place a transvenous lead, in this particular anatomy, they would usually place an epicardial ventricular pacing lead in the setting of heart block, which this, of course, is not, but I'm just making that point. Ivana asked whether she thought this was possibly WPW or pre-excitation. Do you agree with that possible analysis, or do you feel it is likely untrue?
I think the PR interval on most of the beats that seem to be conducted seem reasonable. So at least on this, I don't think there's pre-excitation.
That's right. And again, I would remind you that you would need a 12 lead to confirm this, but in a patient with Epstein's, if you see a complete right bundle branch, usually that is a sign that there is not pre-excitation. And so, in fact, after a successful ablation of WPW, you are usually looking for a right bundle branch block pattern to the QRS. And so this is an important clue. So what are you going to do about this? So the nurse is concerned about this and is speaking with you about it. First of all, what do you make of the size of the QRS and the P wave? Ivana made a point that the QRS seemed to her to be small.
I can't see if this is half standard, full standard. It is full standard. Or no, it says half standard on the first one, no?
I think it says 1 millivolt is, it's telling you what 1 millivolt is. So I guess it's half standard because it's 2 boxes for 1 millivolt. So
right. So then it's probably okay, like the QRS voltages.
And what do you think about the P wave relative to the QRS? If whatever the voltage, whether it's half or regular.
Yeah, the P's are prominent.
Right.
Yeah, the P's are prominent. So, and that's not
in an Epstein's.
I mean, not surprising because you would expect big right atrium, so you would have prominent P waves, which we see as we see in comparison to QRS, they're big.
That's correct. And the other thing is if you're really concerned about that, then what you ought to do, of course, is get a 12 lead.
Right.
So what are you going to do about this?
So is the patient hemodynamically stable in terms of blood pressures?
Yes, she's playing Monopoly in bed.
I mean, I'm not happy with this, but I think we can observe. And this is how long after the valve placement? Days worth?
I would say 4 days.
4 days. Yeah, I would just observe.
Okay. I think that's right. We probably wouldn't rush to do anything for this patient. It is interesting that a patient would have sinus node dysfunction after this type of surgery. One thing you might want to do is if there are wires, you might want to at least test the AV node by just doing rapid atrial pacing to see at what point the patient wanky pox. But probably probably nothing more than that. So,
Yeah.
okay. All right. This is a 1-day-old full-term girl, and this is the patient's rhythm. And I think David Barris is on the line. Welcome back, David.
Thanks, Dr. Pass.
What do you think's going on here? What do you want to do? Anything, either diagnostic or interventional?
So taking, this is a 1-day-old full term, and I assume that there was no cardiac surgery done on this baby.
There has been no cardiac surgery in this baby.
So we have so it looks like our rate is at least above 220.
Yeah, it says at the top of the screen, it's 234 beats per minute.
So that's pretty close to where I would think that this is some sort of SVT rather than a sinus tachycardia.
Okay.
I'm just looking for my P waves right now, and I could see, I think I see P waves pretty clearly in, I'm looking at V1 right now.
Uh-huh.
And in V1, there's, I see two deflections that could theoretically be, P waves. One is coming after the QRS complex, and that's those right, the ones that you're identifying with your mouse right now. But then there's also another deflection that's coming right before the QRS complex.
Uh-huh.
I'm just trying to look at some of the other leads to see concurrently with that, to see what which I think is more definitively a P wave. And I would say I think it's the ones that are coming right before it.
Mm-hmm.
Which would be a very short, looks like a short PR interval.
Yep. I agree with that.
The thing is if, so I'm trying to think about my differential now with P waves coming right before the QRS like that. So it would be EAT versus like a sinus tachycardia. I think that would be my main consideration.
So I think that there are 2 P waves or 1 P wave.
Yeah, so that's another good notion. So then it could be if those are both P waves and the second set is not some sort of P wave, then if it was 2 P waves, it could be 2-to-1 block with some sort of flutter.
So if I said to you, David, you're the fellow on call, or let's say you're the attending and you're doing consult service for the NICU. Mm-hmm. And the NICU fellow calls you and says, we have a baby who has a heart rate of 234. That's 1-day-old, has no murmur or anything, and you are assuming has no structural heart disease. You're correct to say that at 234, it is very unlikely that the patient is in sinus. It's possible, but very rare. So then, is this, what's number one in your differential, even without looking at an EKG? Because, oftentimes having a good understanding of what happens at different heart rates is very useful in informing your interpretation of the electrocardiogram. So if you have a baby who has a heart rate of, let's say for the sake of discussion, it's 240. Is that consistent with orthodromic reentrant tachycardia or AVNRT in a 1-day-old? What heart rate would you expect those rates to be? Would it be 240?
I think it can be 240.
Okay, that's.
I mean, it could be. It could be, but I think it might be more.
What's
likely
the most likely heart rate, though, that you would see in a newborn or a 1-day-old who's having?
More like 260?
It's really more like 300. Usually little babies have very fast heart rates. 260, certainly. I would say anything from 260 to 300 is usually the heart rate that you see in newborns who have SVT. So 240 is notably slow for that in a baby. Now you could have, of course, there are exceptions to every rule, but I think my point I'm trying to make is if you see a baby whose heart rate is not as high as 250 to 300, but is not in the sinus range, the likelihood is low that this is ORT. And in fact, the most likely thing that this is atrial flutter in a newborn. And so when someone tells you they have a baby with a heart rate of 240, the first thing that should come to your mind probably is this atrial flutter? And that's important because when you're looking at the EKG, it might actually be good to be a bit biased and have an idea. And I think we could, if you look here in V1, I think it's very easy to see, as you pointed out astutely, that there are in fact 2 P waves for every QRS, and the atrial rate is about 460, 470 beats per minute, which is a very typical atrial flutter rate in a newborn. And so, you know, and if you look here in the rhythm strip in V1, I think it's pretty clear. And you're right, this P wave is too close to the QRS to be conducting. So probably this P wave is conducting to the QRS, and this one is not conducting at all, and so on and so forth. And I would remind you, I've mentioned this previously, the best lead to look for P waves in most patients is V1 and the inferior leads. And I've mentioned this a number of times, but many years ago, I wrote a paper with Leo Lieberman when I was still at Columbia, and we looked at, and Tom Stark, and we took the EKGs of about 50 patients who we ablated, and so we knew exactly what arrhythmia they had based on intracardiac EP study. And we took EKGs and tachycardia, and we cut the EKG up into 12 little boxes so that you had each lead independently. And I and Lieberman sat down and we reviewed every single lead without knowing what the patient had. And we discovered that a combination of lead 3 and V1, but V1 was the best, were particularly useful at making the diagnosis. That if you looked at V1 and lead 3, you could make the diagnosis correctly like over 95% of the time, which is not intuitive because most ICUs display lead 2 on the screen, which is disappointing and unfortunate because it's not a particularly good lead to look at that. And we thought we would change the world with this observation, but we have not. But the point I'm trying to make is that you're seeing that, you know, I think it's pretty clear that there are 2 to 1. Now, I would argue that you don't have to give this patient adenosine to make this diagnosis, but some people would give adenosine and like to show a big long strip of P waves without QRSs. So now you've made this diagnosis, David. What do you want to do about this?
You can do synchronized cardioversion.
Absolutely. And how much would you give?
So you can do half to 1 joules per kilo.
Yeah, I think that's right. You could give half a joule per kilo. Again, we did a study showing that 1/3 of a joule per kilo was effective in most patients for an SVT. But yes, I would certainly give, probably I would just give 1 joule per kilo because the dose is so small. Some of the defibrillators won't let you go below 2 joules anyways. So yes, you would do that. So now you've cardioverted the patient, and what do you want to do about it now? So you're in sinus rhythm, and you're now talking to the mother of the patient who's justifiably worried. What are you going to tell her about the natural history of their child and what you're going to be watching for? How long do you want to watch a baby in the hospital? What do you want to do about it? Any therapy, follow-up? How are you going to manage this?
Usually the prognosis is good afterwards. So I think we would just want to watch the baby without wanting to start any medication. I think it's like a 15 to 20% chance that it could recur. And then in that case, we could do propranolol or sotalol. In terms of how long you want to watch, I'm not sure if you'd keep the baby more than a couple days extra, but I'm not totally certain on that one.
Well, you're correct. It is very, thankfully, the natural history of this is very positive, and it is unusual that patients recur. I think it's really a little bit less positive than you suggested. I think it's more like 75% of the time you cardiovert and you're one and done, and you never need to do anything ever again. But 25% of the time, we do have to treat the patient. In fact, some of you may remember we recently had a baby that we had to treat with ultimately with Sotalol, kept coming back. Actually had quite a bit of trouble converting. In fact, it took a few days before we could get the baby out of atrial flutter. But even in that circumstance, the natural history would be very favorable. I normally would watch somebody for 48 to 72 hours to make sure a patient doesn't recur. There's no right answer to that. That's mostly a style question, but I would normally, in my experience, most of the time when it recurs by the next day. So you could argue that 48 hours is adequate. I usually watch 2 or 3 days. So, okay. And I would normally treat this, if one needed to treat it, I would treat probably a minimum of 6 months. But it is extremely unusual once you stop meds that it will recur. I don't know that anyone's ever done a study to see if what happens to those patients later in life, if they are more prone to other arrhythmias, but might be marginally interesting. Okay. All right, this is an example of a patient with WPW. And the question I'm asking is, based on the morphology of the WPW, where do you believe that the accessory pathway is located? So why is this question important? It's important because when you're thinking about referring a patient to the cath lab for ablation, having some sense of where the pathway is somewhat useful. For example, if you knew based on the surface ECG that the pathway was located near to the AV node, you might be inclined to wait until a patient was older, larger, and the distance between structures presumably larger. Whereas if you thought it was, shall we say, left lateral, you might be willing to do it at a much younger age where the risk of injuring the AV node would be markedly less because of the greater physical distance between the pathway and the node. So being able to at least get a general gestalt or sense of where the pathway is, at least right side versus left side, is of value. So with that as a background, I'm going to call our cardiologist from Alabama, Dr. Uzoma Obiaka, to see if she has any thoughts on where her patient's accessory pathway is located.
Good morning, Dr. Paz.
Good morning, Dr. Obiaka.
I would use the Arruda principle protocol. Don't have it memorized, so it would have to be like a step-by-step thing, but I don't have it.
I will do it with you, but before we do it, you should at least, based on the surface, be able to tell if it is right or left-sided. Do you have a sense of that?
I would say left-sided, and this is me just...
Well, you had a 50-50 chance.
Oh, so
today was not a good day to flip the coin. So this is in fact a right-sided pathway. And generally the rule of thumb is that if the morphology of the QRS in pre-excitation is a left bundle, it is typically a right-sided pathway. And if it is a right bundle, it is typically a left-sided pathway. Okay, and so I think we would agree that the morphology of this QRS is certainly more of a left bundle morphology.
Which is why I said it was a left-sided, yeah. So it's the other way around.
It's the opposite, but good thought. So let's go through the Arruda map. And I remind you that there are many of these algorithms, but I find this one is pretty easy. This comes from the University of Oklahoma from a guy named Sonny Jackman, who is the first person ever to have performed an RF ablation in a human being and is considered one of the real gurus of electrophysiology. So let's go through it here. So step one is to look at lead one and see if the delta wave, now when they're talking about all of this, they're talking about the axis of the delta wave, positive, negative, or isoelectric. So in lead one, we see that our delta wave is largely positive.
Positive, yeah.
So we are not isoelectric, and we are not negative. And in B1, the S wave is clearly much
greater
than
the R
wave. So we do not meet any of these criteria. So the answer to all this is no. So we have to go to step two. In step 2, we're looking to see if in lead 2
Yeah.
is the delta wave negative, and I think we would agree
No,
that it's
it
positive.
is not. Yeah.
Now, this is an interesting observation, very high sensitivity, usually very accurate. If you see lead 2 negative delta wave, it puts it in the coronary sinus or the mouth of the coronary sinus. Very accurate. It's very rare that it's wrong. Okay, so now we're on step 3. Is the V1 isoelectric or negative? I think it's probably
It looks
mostly
more negative.
Yeah, I think that's right. So now it's putting us in the septum. And we
septum.
already know this is a right-sided pathway based on our left bundle versus right bundle. Now we're going to look at the QRS axis. And is AVF positive? No.
Negative.
It's negative, I think. And
Yeah.
so is it, it's either isoelectric or negative. It's probably negative.
Negative. So
But
right.
this would suggest that the
It's receptor.
pathway is actually right posterior or right lateral, right posterolateral. Okay. So this is a pathway that is on the right side, but not that close to the AV node, sort of near the, maybe near the, when we say right posterior, we're usually referring to the area near to the coronary sinus or below or slightly anterior of the coronary sinus, that general region. Now, these are not guarantees, of course, but this is usually fairly accurate and at least giving you a gestalt of where the pathway is going to be located. So, okay, very good. And I can tell you, Dr. Obiake, if you call your electrophysiologist in Alabama and say, I have a WPW patient I'd like to refer to you, and I believe it's a right posterior pathway, and you have used your Arruda map and have correctly identified it, the electrophysiologist will have tremendous respect for you forever. So.
Thank you, Dr. Pass. And I will not give the credit to you. I will take all the credit so I can
think that you
sound
certainly
smarter.
should take all the credit because you will. And we know that the electrophysiologist will be impressed by you anyways, but we really want it to go over the top. That's the way to do it. Okay. So this will be our last tracing of the day. This is a 10-year-old Fontan walks into your office, and this is the EKG. So I am going to direct this question to Dr. Grace Kong of New York, New York.
Hi, Dr. Pass. Good morning.
Instead of Texas. What do you think, Grace Kong?
Yeah, I think that we are in, well, I see P waves that are not getting all conducted. And the P waves seem to be in regular intervals. So I'm concerned about a flutter. The rate of the P waves itself, I think, is probably 150, around 100, 120, maybe.
Wait, I'm not sure I agree with that
Oh,
statement.
100.
I don't know about that. It looks pretty slow. Like, let's look in V1. We just said how V1 is a nice way to look at P waves. I think that this is, yeah, it's about 100 beats per minute. That's right. Maybe even a little slower here.
Yeah. So the P waves are not actually very fast to say flutter.
That's my point. Yeah.
But we're not conducting.
When you started, you said, I didn't see any, it doesn't seem like they're mostly conducting. Are they conducting at all?
So I'm looking at the PR intervals and it looks to vary with every QRS. So it could be complete heart block. Let me look at the QRS intervals. They are very regular actually. So yeah, probably in third degree.
Right. So of course, it always seems that whenever we have a patient who has a tracing like this, Robin only prints out the 12 lead and no rhythm strip. So there's, of course, no rhythm strip in this particular patient, which is unfortunate, but it's just kind of funny. But so yes, the fact that the R to R interval is very regular is very highly suggestive with no discernible consistent relationship between the P waves and the QRS would be very suggestive of heart block. At the very least, it's advanced second degree heart block, but we don't really know Now, when an old EKG was pulled out from 6 months earlier, this patient was conducting and had a QRS morphology that looked exactly like this. So what do you want to do about this? Let's assume that it's happened this week. I don't know when this was, but let's for the sake of the case, let's say it happened recently.
I would do a Holter.
Absolutely. You want to do a Holter to see if this is, in fact, complete heart block. Patient feels fine, by the way. So you do a Holter, and what you see is there are periods where there is some conduction, but mostly it looks like this. So essentially, the Holter shows high-grade second-degree AV block. Is there any kind of workup you want to do on this patient beyond a Holter?
Muted.
Are you there, Grace?
Can you hear me, Dr. Pess?
Now I can. Yeah.
Okay. Thank you. Sorry, I think I was muted. I would send thyroid studies. I would send Lyme studies.
I agree with both of those excellent suggestions. Any other tests other than that in 2021?
Electrolytes.
Electrolytes, the old favorite. Yes, you can send your electrolytes.
Viral panel, see if he's had a viral infection.
Yeah, you could send a viral panel. Any other tests? I agree with all these decisions.
Not sure what else.
Well, one could have myocarditis, right? That causes heart block. So you might want to send a SED rate or a CRP, right, to see if there's inflammation. And are there any, are you familiar with the fact that we are in the middle of a pandemic at this time?
So maybe a COVID test.
Might be worth doing a COVID test and a COVID antibody, right? Because patients who, it's been described now, there was a paper, in fact, I believe in Journal Club, we reviewed recently a paper from the group in Boston showing that there was an incidence of AV block, at least transient, in patients who had COVID. Any other testing you would do beyond that blood work? Any other kinds of tests?
I would get an echo again, look at function.
Right, because you'd want to know. Unfortunately, this particular patient has bad function at baseline, and it didn't look any different.
Oh.
Okay, but you would want to do all of that. And it turned out the patient had COVID antibodies. And so I think, anyway, the evaluation is ongoing. But obviously, the decision to place a pacemaker in a Fontan patient is a big one because we can't generally or easily place transvenous leads because of the risk for thrombosis. We can't get into the ventricle at all. And even if we could, the risk for stroke is astronomically high. So Fontan patients, as a general rule, need to be paced epicardially. Now, on rare occasions, we will pace transvenously the atrium in these patients if we have absolutely no other options, but it is not the preferred approach. The preferred approach is epicardial pacing in these patients. And that obviously involves a fairly major surgery with, and in fact, in a patient like this, what we would normally do is get a CT scan of the chest. And the reason we would do that is it would allow the surgeon to see where the atrium and the ventricle are most easily accessible for pacing. And usually in a Fontan patient who has had multiple surgeries on their atrium and on their heart in general, because epicardial leads require a really nice, clean, shall we say, pristine area of myocardium, the surgeon is trying to look for areas that have not been touched previously by surgery. And when it comes to the atrium, the best place usually is the left atrium because most patients, even Fontan patients, have not had surgery on their left atrium. So what the surgeon is looking for in a CAT scan is to see if there would be an area where through a thoracotomy, they could access both the ventricle and the atrium. So classically, a case like this, you would maybe see if, like from a left thoracotomy, could you put a wire on maybe the left atrial appendage and on the LV. And that was, in fact, the thought pattern of the surgeon. So, so what's happening now is we're waiting a brief period of time to see if conduction recovers, and if it does not, then a CT scan will be obtained in order to help plan surgery. Because in some patients, even in the setting of levocardia, patient may not have very much atrial mass on the left side from which the surgeon to work, because if they can't access it that way, then they may need to do a median sternotomy, which is obviously a very big deal in a multiple re-op patient. So, and with that, I think we'll stop for today. Thank you all very much for joining. I will see you in conference in just a few minutes. I hope everybody has a wonderful week.
Thank you.
Thank you.
Thank you.